Good morning. This is Dr. Nancy Dickey. I'm the director for the A&M Rural and Community Health Institute, as well as the Center for Optimizing Rural Health. I want to welcome all of you to the kickoff webinar for year 2 of the Vulnerable Rural Hospital Technical Assistance Project. As director of the center and co-PI with Dr. Woodsack for this HRSA project, we're pleased to have you join us today, and we hope each of you will submit an application when the portal opens in a few days. The purpose of today's webinar is, of course, to walk you through that application process, and Dr. Woodsack is going to do that in some detail. While we've tried to anticipate any of your questions, we, of course, will entertain your questions through the webinar today, and the leaders and staff will be available at CORH to assist you in any fashion we can once you get ready to apply. We believe we've had a wonderful start in year 1. We'll be continuing to work with the year 1 hospitals through December of 2019 and are very eager to hear from all of you as potential applicants for year 2. We find that in working with small hospitals, many of you have best practices to share, and many of you can benefit from the activities that have been designed by your colleagues. So welcome to the webinar. Hopefully this is the start of a very productive relationship between A&M, the Center for Optimizing Rural Health, and each of you. Thank you. Dr. Woodsack, it's all yours.
Thank you for the chat connection, letting us know that you couldn't hear us. We'll start over again. So the official verbiage that I need to share with you is that this webinar is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, under Cooperative Agreement U2-BRH 32163. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. It's a 5-year cooperative agreement, and our year 2 starts on September 1st. We're going to cover today who we are, what we do, and then how you can connect with us. So CORH, the Center for Optimizing Rural Health, is a technical assistance center. We offer 3 types of support. On-site, we will come and visit you. Remote facilitated assistance, where we do everything by phone, webinars, etc., and self-directed access to best practices, resources, and tools. That's our 3 tiers. Tier 1 and 2 receive targeted in-depth assistance by subject matter experts. And targeted means we realize one size does not fit all, and we want to make sure that what we are suggesting and working with you on fits the needs of you and your community. The technical assistance is to assist hospitals and their communities to address economic challenges, understand community needs and resources, and find ways to ensure hospitals and communities can keep needed care locally. And in case you're worried that we have a very Texas-centric focus, since we are located at Texas A&M, be assured we have a National Advisory Board, and they help ensure relevance across the United States. While the center is a relatively new creation, we are in year 2 of this cooperative agreement, it is housed in ARCHI, which is the A&M Rural and Community Health Institute. ARCHI has strong rural roots and over 15 years of supporting rural health. The mission of ARCHI is to improve access to health care and reduce disparities of health status and outcomes by improving the quality and safety of health care. And our vision is to be recognized as the premier health services organization that advances the optimization of safe, effective, quality health care and informs health policy through innovative technology, service, education, and research. So CORH is housed in ARCHI, which is part of Texas A&M. Our team members, we have Dr. Nancy Dickey, she's our principal investigator at CORH, and she's the president emeritus at Texas A&M Health Science Center and the executive director for ARCHI. Myself, Bree Woodsack, I'm your co-principal investigator, and at CORH, I'm the director of technical assistance. My co-PI is Dr. Jane Bolin, and she is also the Associate Dean for Research at the College of Nursing. Andrea Brewer is our project director for CORH. We're also joined by Lene Hutchison. She's part of our evaluation team. Peter Yu, our Director of Technology and Research, Cassidy Avila, our Outreach and Training Manager, Kim Cassins, our Echo Network Manager, Robin Arnold, our Project Coordinator, Melissa Garza, our Financial Analyst, Sam Stiegel, our Web Manager, and Angie Alaniz, the Director for Rural Healthcare across our Access programs. And I want to just give you a snapshot of our team today. So Dr. Dickey is actually on location at a rural hospital with Angie and Kim. While in the room, Cassidy, who did all the outreach to make sure everybody could be here today, is assisting. And Sam is helping our webinar run smoothly now that we have our sound fixed. Andrea is also standing by with all our data in case we need it during the Q&A session. And then I got voted to do the talking for you today, just to kind of give you a snapshot of who's with you for this. So looking at what do we do, we provide technical assistance, and we have that three-tiered approach. The tier 1, where we can visit you, the tier 2, where there's no visit to your location, but it's still targeted technical assistance, and then tier 3 is self-directed. A deeper dive into tier 1, we select 5 hospitals each year, and this is our second year that we'll be opening up the portal in September. We meet with your community to learn more about your situation and to help us come up with options that are relevant and meaningful to you. That's how we deliver targeted technical assistance, because right-sizing involves right-serving. And so that's why we have the on-site virtual communication and a comprehensive assessment to make sure that our reports and strategies are meaningful and relevant to you. We will have ongoing technical assistance by the team, mentoring, facilitated peer-to-peer project Echo Network, which is case-based learning for hospital administration, where you learn from your rural peers as well as subject matter experts, and monthly webinars on topics that are suggested by our hospitals that we've been working with. Tier 2 is remotely facilitated technical assistance. Each year, we'll select 25 hospitals to be in this cohort, and they have the virtual facilitated intervention through educational materials, monthly webinars, and the echoes as well. They have individual coaching sessions. These are our touch points throughout the year to really get to know them and their community without us traveling there. And then communities that are selected for tier 2 can apply for tier 1 in subsequent years. So this is a tailored technical assistance approach as well. Our tier 3 self-directed technical assistance, they have open access to webinars and a toolbox of best practices on the website. They have the option to schedule brief one-on-one technical assistance calls for specific questions. And the communities that are assigned to level 3 may apply in subsequent years for a higher level of intervention. And what's nice about tier 3 is that once we have your contact information from the application, we can connect with you and let you know about upcoming webinars and other things that are happening. So it's a more targeted involvement to let you know what CORH is doing. Those are the 3 tiers we work with from among our applicants. Let's get into what the application actually looks like. So our application portal window, it will open on September 3rd and it will close on October 31st, 2019. The application does reopen each year because it is a 5-year cooperative agreement, and this is year 2 for a new cohort. Who can apply? Rural hospitals, and that can be PPS or critical access. So PPS, if you don't know if you're rural or not, please use the Federal Office of Rural Health Policy, FORP, eligibility analyzer, and the website is on there. And don't worry about writing all this down. We will send those slides out. The recording will be posted on our website, and the application itself has inclusion and exclusion criteria, so that you can revisit that and make sure that you fit. Who else is eligible? Hospitals operated by tribes and tribal organizations. Rural hospitals evaluating healthcare services provides to the community, which may exclude inpatient services, so those that are right servicing. And if you're unsure of your rural eligibility, again, you can check the FORP eligibility analyzer. Now, who cannot apply? 2 groups, that's it. Everybody else that's rural can. So those 2 groups are those hospitals that are participating in other HRSA-funded in-depth technical assistance. And those are defined as the Delta Region Health Systems or the Small Rural Hospital Transitions Program. So if you are already in Delta or SHRT, you're not eligible to apply for this technical assistance. If you are a hospital that's participating in the Medicare Rural Hospital Flexibility Grant or the Small Rural Hospital Improvement Project, so if you're in SHIP or FLEX, you are still eligible. Now, if you don't know your status, please apply anyway. We work this part of the cooperative agreement as HRSA will do a due diligence check. So you get the technical assistance that offers you the most. So if you're in the running for multiple programs, HRSA will make sure you get the one that is best fit for you. So please apply. Now, who can submit this? Anyone can complete the application for the hospital. So it can be your CEO, your upper administration, grant writer, State Office of Rural Health, anybody that you want to work with, because we realize how many hats you wear at the rural hospital. So please find friends and work on this together. How long will it take you to complete this? Hospitals last year told us it took 60 to 90 minutes to complete. There will be a PDF with all the questions on our website so that you can prepare in advance of sitting down and doing this online. And there's 5 main sections, and I will go into those for you. So we designed these sections to give us enough information to make an informed selection while keeping in mind how busy you are and trying to minimize your question burden. All right. So the 5 main sections are health of the community, community facility level of readiness to participate, level of vulnerability, distance to nearby health access, and partnerships. Section 1, health of the community, is worth 10 points out of 100. And these are the basic demographics of you. So we want to know the name of your hospital and what state you're in. We want to know a point of contact. So we're going to ask for the name and contact information for the applicant. We want to know if you're critical access or prospective payment. Are you part of a system? Do you have an external management company? And what business entity pays the salary of the CEO? This gives us an idea of the layers involved with any change implementation. We want to know the size of your hospital, your 5 most important service lines, population size of the community and of the catchment area, looking at the square mile geographic size of the catchment area, and do you have a tax support for your hospital? We also want to look at your community status. So we want to know if the population in your county or city is growing or declining, the average age of your population and their average income. What does your payer mix look like? Have you had new industry or loss of industry to your community? And then looking at school enrollments increasing or decreasing. Numbers are great, but if you don't know numbers, we're looking for increase or decrease. Section 2 is community facility level of readiness to participate, and this one is worth 20 points. So CORH provides technical assistance, but this is a working program. So we are looking for communities that are ready and willing to work to retain access to care for their community. So that's what these questions are geared at. And as a note, we want to let you know that we're going to be looking at the level of effort and initiative to address the health of your hospital and access to care. Not necessarily that you've implemented them and you've got 5 years of data and you've got a 20% return on your efforts. We just, whatever you're doing, we want to know where you are at in that stage. So the first question, on a scale of 1 to 5, and we will have a Likert scale on the application, how does your community leadership perceive the need for your hospital to remain open? Community leadership is by your definition. So the mayor, church leaders, city council, school boards, who leads in your community and what do they think? That's what we're looking for. Does your community leadership support expanded efforts in the community to address the sustainability of your hospital or access to care concerns? And we'll have a place where you can say yes or no, and then a place where you can provide more information. Next, we're going to look at what does your hospital board think? So at the Likert scale again, how does your hospital board perceive the need for your hospital to remain open, and give us some description? And then is your hospital board actively engaged with the hospital leadership to address the health of your hospital? Yes or no, and we'll ask for more details on those again. We want to see if there's unity of purpose and that everybody's pulling together, or is there some disagreement there? And to be honest, we've had hospitals this year that are in our cohort that struggle with their boards. So that's not necessarily a disqualification. it gives us a point to start working on it with them, that we need to get the hospital board and the hospital leadership in alignment in order to make change. On the next slide, now we're looking at community members. So this is the general public. On a scale of 1 to 5, how do your community members perceive the need for your hospital to remain open? We're going to ask you for some details if you can. What type of information is publicly available to your community about the vulnerability of your hospital or rural hospitals in general? And then on this page, the last question is for you, the applicant. On a scale from 1 to 5, has your concern for the health of your hospital decreased or increased in the last 12 months? And this is to give us a sense of your urgency. We also want to know about hospital administration. Is the administration currently seeking knowledge on how to improve the health of the hospital? We're going to ask for details. Are there efforts in your community to address the health of your hospital or access to care concerns? And we'll ask you to describe those if you do have them. And if no, are you working on getting those started? So again, we want to see where you are at. If selected, are you willing to serve as a mentor to other healthcare facilities in upcoming years to share lessons learned and best practices implemented? We envision an alumni group where we have those hospitals that have come before help pass the knowledge forward. We've already started this with some of our hospitals that are in the cohort together. When we find one hospital that's done a service that another hospital is looking at, we've had mentoring within the same cohort. So we're just asking for your willingness after you've been through our program to serve as a mentor to those that come after. Section 3, level of vulnerability. This is the big one that's worth 50 points. And we're looking at 2 different perspectives here. We're going to get the historical perspective by getting the Financial Distress Index calculated by the University of North Carolina Shep Center. And we're going to partner that with the current data that you provide. So the current data that we'll ask from you will be on quality and experience, your 30-day readmission rate, your patient fall rate, your medication error rate, and patient willingness to recommend. We're also going to look for operations. We're going to ask for your average daily census, acute and swing beds, your average length of stay for acute, labor as percentage of expenses, and we'll ask for with and without physician contracts, finance for the previous fiscal year. We're going to ask for your total margin, your operating margin, your net revenue, current ratio, debt service ratio, net accounts receivable days, and days cash on hand. All right, let me get a drink of water, and then we'll move on to section 4. Distance from the applicant community to the next nearest hospital access, and this is worth 10 points. This gives us a sense of where you are and what options does your community currently have. We want to just get the big picture for access to care discussions. We are going to ask the name and location of the next 3 facilities of similar or larger size, the distance of these facilities from the applicant in miles and time to travel. And we ask this because in Texas, we acknowledge we have 12 months of hot, which means that I don't have to worry about snow. So 30 miles is always 30 miles. But we know that in some places, 30 miles in the winter can take 3 to 4 times as long as 30 miles in the summer. So trying to be mindful and ask for distance as well as time. What experience you have in partnering or collaborating with any of the proximate facilities. For example, you may share an orthopod who works for you 3 days and your next closest hospital for 2 days. Or you guys work to get patients from one place to another for swing beds. Are you tracking where patients go and for what services they leave town? Are you looking at out-migration? And when we ask for you to please describe, we want to know if the out-migration is this loss of business that might be altered, or is this a coordinated division of specialties and done with intention so that each of you and your partnering facilities have a special service line and you refer to each other? So that's what we're looking for with the out-migration. The final section, partnerships, is worth 10 points. These questions are designed to let us know if you are standing alone or are you already working with others. And again, for this section, we are looking at the level and initiative to establish partnerships, even if those initiatives are not complete or haven't been successful. We just want to know what you've been doing. So we will ask, are there local organizations or coalitions that deal with access to healthcare issues? Are there local individuals or organizations that could be enlisted to provide support for access to healthcare concerns? And please list those. What work have you done, or are you in discussions to do with philanthropic funding partners or local organizations to indicate community buy-in or capacity to partner? And there will be room for description. And I want to let you know, last year we had this question come up. There is not a word limit, but if you happen to hit or find a word limit, send us an email that we can, if you send us the name of your hospital and who you are, we can link it to what you've submitted in the application. We want to make sure you submit a complete packet. So don't feel obligated to keep typing and typing, but if we have shortchanged you on the space available, please just send us a supplemental email. All right. Acknowledgement of MOU, which is a Memorandum of Understanding. We added this item this year because we want to minimize the paperwork phase and maximize the working relationship time that we have with you. So all this says is I acknowledge that if selected, an MOU will need to be signed. The MOU will be posted on our CORH website. The MOU will be with the frequently asked questions as well as the PDF of the application. So you can get all three documents before you apply. And we want you to know that in order for CORH to provide a full year of technical assistance, applicants were asking you to review the MOU to ascertain there are not any absolute contraindications to your signature. Now, please, if you have concerns about the MOU, please still apply. Reach out to us with those concerns so we have as much time as possible to address your concerns. So we can be talking while the application portal is open. Last year we lost some time working through all this legal, and we're trying to minimize that this year so that we have as much working time with you as possible. So that's why we're asking you to review it in advance. And then the press release option, the last item on the application. If selected, I acknowledge that my facility may or could be named in press releases. You do have the option to identify either how you want to be listed. So you can say my name is Get Well Hospital in College Station, Texas, or you can list yourself anonymously as, please for press releases, just list me as a hospital in Texas. We leave that to you, and we do that because we know some communities don't understand that all rural hospitals are vulnerable, and we understand that that's a discussion you need to have with your community, and it doesn't need to come as a surprise in a press release from us. So we just want to know how you would like to be listed. If that press release helps you, please let us know your full legal name. And if you don't think that press release will help you, please tell us how de-identified you would like that to be. And that's the entire application. So what are your next steps? The application portal will open on September 3rd, which is next Tuesday, and it will stay open through the very end of October 31st. We will then review all the applications and we will notify selected hospitals in December of 2019. So please make sure that whoever is your contact person, that they have their preferred method of contact in the application, because that's how we will reach out to you. Please also monitor our website for new materials. The website is there. We have webinars every month. You can go to those now. Our next webinar is September 10th at noon. It's Ask the Experts, where we're talking about, we have experts from community engagement, marketing, and finance. And then you have the past year of our webinars are recorded on our website, so if you missed it, you can go back and watch those and catch up. Please follow us on social media, see what we're up to. We have Twitter and LinkedIn, but then we do also like to meet people live and in person. So if you are attending any of these rural conferences, we'd love to connect. We will be at the Critical Access Hospital Conference in Kansas City, Missouri. That's September 18th through 20th. And the NOSOR annual meeting in Albuquerque, New Mexico in October. So my name's Bree Watsack. And if you want to just cyber stalk me while we're there through the conference app, feel free, or you can send us an email ahead of time and we can make sure we set up a meeting and have some face-to-face time. I want to thank you for joining us. I've included the email and phone number for the Center for Optimizing Rural Health. We are going to open it up for questions at this time, and Cassidy is going to unmute so you can talk. And then we also have the chat function, so you can submit questions via chat. And we will compile a frequently asked questions, make sure that they are on our webpage for you to view. And we do welcome questions if you have questions as you're going through the application. Cassidy, how are we looking for questions and unmuting?
So anyone that would like to unmute themselves now has that option.
Okay.
You're still muted, but if you have a question that you would like to speak to us, then please unmute yourselves. You also have the option to type your question into the chat box. So we can just give everyone a couple of minutes to type their question.
Certainly.
Okay, so we have a private question. If your financial condition has changed significantly from the previous fiscal year, where would you describe this, or what options are available?
That is a good question. Yes, and so that's, again, for the finance section, while we're looking at the historical data as well as your new data, because we realize that this changes. So you could, in the level of vulnerability, those are mostly number questions that we ask, but we will make sure that you have, I think we're the best place to put that for finance. Sam, do we have a place in the finance where we could ask an other and just say if there any additional information you would like to provide? We will add that. We will add a other option in case you need to describe what has happened to you in the past year. Like in case the #1 employer in town closed, that would significantly impact a hospital. Great question.
Okay, we do have a couple more questions. Are rural clinics without inpatient capability allowed to apply?
So we had that question come in this year about rural clinics without inpatient. Okay, so this year HRSA wanted us to focus on hospitals, but if you are a hospital that is transitioning to a rural clinic, I was going to reread our inclusion criteria that are rural hospitals that are evaluating healthcare services provided to the community, which may exclude inpatient services, are eligible to apply. So it depends on if you are currently a hospital and transitioning to something else, we can help. But if you are currently not a hospital, the answer is no.
Okay, next question. Does Tier 1 tend to be a higher or lower score?
The way the rubric works, Tier 1s have higher scores because they indicate a higher level of vulnerability and a greater level of readiness to change. They have a higher score.
And so someone else on the group chat wanted to confirm that, and they were correct. They said what you said to the group. Another question that came up in the chat, is there a fee for each tier with CORH?
No, this is free. You don't pay anything. Conversely, we don't pay you anything. We had some hospitals last year that thought they would get money from us. There is no money that exchanges hands between CORH and the hospitals. HRSA has provided us what we need to offer this service to you.
Next question in the chat. We are a current SRHT project site. Would we be allowed to apply for this CORH program next year after the SRHT project is complete?
I believe you are. HRSA told us you couldn't be active in both, but I will follow up and confirm. Cassidy, if you have the contact information for that person.
I do.
Okay, we will follow up with you. But based on what they said last year, I would say you can apply.
Another question in the chat. Can we apply for each of our 4 critical access hospitals?
Yes. So we had a group apply this year, and we said, please, it was a group of 7. We had them each apply as individuals, but they had a grant maker that kind of coordinated the effort. So yes, one person can apply for 4 separate hospitals. That's fine.
Next question privately in the chat. If we are having internal discussions of closure, can we still apply? Are you still able to help us?
Yes. Yes. So if you are currently an open hospital, but you've had that secret meeting that you won't stay open throughout the year when we're providing technical assistance, we're about helping with access to care. And so we could walk that journey with you and work with you through the process where you may have to close the doors to the hospital, but we could help you right-size access to care in your community and make sure that you can retain some of the services that might otherwise just leave. Yes, they can apply.
Okay, next question in the chat. Who is the point of contact on our end if we apply and are selected for the program?
So if a hospital applies, we will initially reach back out to whatever name and method of contact they gave us. So it could be your phone number or your email. And we'll say, welcome, you've been selected, congratulations. We want to set up a welcome call. And then during the welcome call, we will ask, who would you like us to coordinate with moving forward? And so then you can give us a team. So some of our hospitals, we have 3 or 4 people that we just include on our monthly communications and all our invitations. And other hospitals have one point of contact, and that person distributes as needed to whoever they want to at their facility. So the one person to get the letter from us, and then during the welcome call that follows, we'll make sure we get your preferred method of contact moving forward.
Okay, those are all the questions currently in the queue. So if anyone else has a question, we still have plenty of time for Q&A. You can unmute yourself, or you can type it privately to me, Cassidy Avila, in the chat box, or you can type it for the entire group to see into the chat box.
So while we're waiting and people are thinking of questions, let me share with you the top requests we got this year for technical assistance. They were looking for charge master and cost capture, coding and auditing in terms of how to get more accurate coding, 1, to make more money, right, to capture what you're actually doing, and 2, to avoid miscoding, which could be troublesome. Community outreach, how to educate your community about what services you have and make sure that they understand the value of the hospital that's right there in their community rather than driving past you to get to a bigger city. Marketing, that was a big one. I was surprised by that one, but both internally to your employees about marketing your facility as well as external to the community. Recruitment and retention of physicians as well as upper level management, that has frequently come up. And then community wellness has been a very popular request for assistance. No?
No more questions at this time.
That's okay. So this was our kickoff webinar, just to let you know what the application would look like. We will have the PDF of the application as well as the MOU and the frequently asked questions. Those will be up on our website by this weekend. And the portal will be live on September 3rd. As soon as we can get this processed, we will get this recording and these slides on our website as well so that you can refer back to them when you're going through the process of filling out your application. And please feel free to reach out if you have any questions at any time. That's what we're here for. Thank you very much for your time, and we're available for questions when you think of them later. Cassie, anything else before we disconnect?
I think that's it. Thank you for joining us.